Right. So I'm going to talk a little bit about some newish tips and tricks with regard to RSI that you may or may not be aware of. And also a bit of a discussion about things that we can do for our RSI protocol here, including the checklist and potentially some new equipment to go through. So RSI in the emergency department's inherently dangerous. The NAP4 study showed that the risk is at least 10 times higher than the risk of doing an RSI in theatre. So for every RSI in the emergency department, we should be appreciating that risk and preparing appropriately for the talk. So I don't know if you've spotted what's going on with Huey here, but he's got his belt and his braces on. So we need a belt and braces approach for our RSI. And for that, we can use the framework of optimizing the patient, preparing the team so that everyone knows their roles and knows what everyone else is going to do. Having an appropriate plan, both the first attempt at intubation, but also backup plans as we need, and then making sure that we've got all of the equipment for all of those plans and that it's there, checked and to hand. Now, I've talked a fair bit on RSI before. So there's a talk on the Western ED website on safe RSI by me. There's a hypoxic RSI talk. There's a shocked RSI talk on there. So if you want to go back and have a look at those, feel free. So we'll start off with a scenario, a relatively straightforward one to start with. So somebody who is anatomically and physiologically normal for RSI. So let's say a 20-year-old man who's had a GHB overdose. He's severely obtunded. He's not looking after his airway. He needs intubating for that reason. But physiologically, he's normal. And on the exam, anatomically, he's normal as well. Now, I think most of us in this situation would pre-oxygenate with a non-rebreather mask and nasal cannulae running at 15 litres per minute each. Some of us might use a bag valve mask instead of the non-rebreather, but do you know what oxygenation this is going to give you with both of these systems running at 15 litres?
Is that about 60 or 70%?
Yeah, it's about there. So Chris Greenbridge, who's an emergency physician at the Alfred, did a study on this with healthy volunteers in a simulated environment, and the expired oxygen concentration with this setup at 15 litres each is about 57%. So it's not a great pre-oxygenation tool as it is. With the non-rebreather alone, without the nasal cannulae, it's 52%. So it's not ideal. So what we can consider using instead is what's called flush rate oxygen. Now there's a trial out of the States where their flow meters, if you over crank them beyond 15 litres, the flow increases even though your rotameter at the top here is still reading just above 15 litres, but their flow meters actually get up above 40 litres per minute. And when they studied this with a flow rate above 40 litres per minute, they're getting an expired oxygen concentration of 86% with a non-rebreather alone, so that's not even with nasal cannulae. And that's better than an anaesthetic circuit. An anaesthetic circuit has an equivalent scoring about 81% for your expired oxygen measurements. Now, the problem that we have in Australia is that our flow meters, if we overcrank them, they don't actually get much beyond 15 litres per minute. If you play with the flow meter, you turn it up and listen, you get to 15 litres, it doesn't get much louder. It probably only gets to 17 or 19 litres per minute as a maximum. So the flow meters we have, we can't overcrank them substantially to increase the FiO2. But what we can do is change the flow meters out. So this actually is in Sunshine ED at the moment. I took a picture of this earlier on in the week. As you can see, it's got a wire, because people steal these things, and it's actually wired to the Airvo high flow nasal cannulae to stop it going walkabout. But this will give us a flow of 70 litres per minute, and you can overcrank this, so you can get way over 100 litres per minute if you overcrank this. But if we were delivering 40 litres per minute plus via our non-rebreather, and we can overcrank the nasal cannulae as well if needs be, we would be getting a much better FiO2 for these patients. And that goes back to the belt and braces approach of essentially increasing the safety, buying us more time, increasing our safe apnea period. These cost about $140 each. And my feeling would be that we should be switching out our flow meters in resus to a higher rate flow meter like this. Just being aware that the little old lady in resus who's on nasal cannulae at 2 litres per minute may be hitting the ceiling if we inadvertently have this. But it's clearly labelled, and as opposed to the overcranking system, we actually know what we're doing here, and we could easily switch these out so that they're in the intubation trolleys for use for pre-oxygenation. The benefit of using the non-rebreather mask over the bag valve mask is that you don't need somebody standing there with a seal onto the face. That's the big drawback of using the bag valve mask. If you're not sealed onto the face, you're actually just giving room air. So, and it's very easy to become distracted when you're pre-oxygenating because you're often the team leader as well. So you're taking your hand off, removing the seal, and actually losing any benefit of pre-oxygenation. So I do personally prefer the non-rebreather technique, but with the higher FiO2, and I think that's the way we should be going for added safety. Something else that we can consider is high flow nasal cannulae. Marty's going to talk about this shortly. There was a study from the UK called the Thrive study using high flow nasal cannulae for pre-oxygenation and apneic oxygenation, but Marty will fill us in on that very shortly. So let's move on to the second case. Now, this case, the patient is hypoxic despite our best efforts at pre-oxygenation with the previous technique. Now, in the ED population, when we're giving oxygen, this essentially means that the patient has a shunt. So no matter how much oxygen we give them, we're not going to overcome that shunt, and they're going to remain hypoxic. So what they need is CPAP in this case. Even if we're giving an FiO2 of 1, we're still not going to improve things. I realise that the observations otherwise are not quite what you'd expect to see with a patient with SATs that low, but there you go. So if we can't get the SATs above 95% with our non-CPAP techniques, what can we do? Well, we can use the bag valve mask with the PEEP valve in place, or we can use a proprietary CPAP device, or we can use the ventilator to deliver CPAP. And given that we're going to be using the ventilator later on anyway, it makes sense to use the ventilator, and I'll come back to that. Now, it's really important, if you're using the bag valve mask with the PEEP valve to deliver CPAP, you have to have nasal cannulae underneath, because there is no fresh gas flow to the mask with the bag valve mask and PEEP. You need the nasal cannulae underneath to generate fresh gas flow and therefore generate pressure. So without the nasal cannulae underneath, the BVM and PEEP system becomes completely redundant for delivering CPAP. And it doesn't deliver the CPAP that you dial up. It'll get somewhere close to it in expiration, but in inspiration, your pressures will actually be lower. So your mean airway pressure is going to be lower than what you'd be getting if you're using CPAP. So it's a poor man's trick, really, if you don't have easy access to CPAP or the ventilator. The other thing in these hypoxic patients that we can consider is to actively bag them during the apnea period to try and prevent desaturation and hypoxia. And really that's a risk-benefit decision with every patient that we have, because a true RSI doesn't involve any ventilation during the apneic period. That's the definition of an RSI, essentially, and the period between induction and intubation is as short as possible. But we might decide to bag them if we decide they're at high risk of becoming hypoxic. And when we do that, we want to go low and slow with the bagging, which can be very difficult when you're a little bit excited in your resus situation. So an alternative that we can use here is using the ventilator as a bag or what's been called VAPOX. VAPOX was a paper published in the EMA from Queensland, where they used the Hamilton ventilator for pre-oxygenation and then apneic ventilation of the patient. Now, you can do it in several ways, and you don't actually need the Hamilton. This is a diagram from their study, which I've modified a little bit. Now, they advocate using NIV-ST, which is the spontaneous timed mode, which means that you set a lowest respiratory rate, and if their breathing rate is below that, it will actually start to attempt to ventilate them, switching between the IPAP and the EPAP that you've set, if that makes sense. So if you've set the NIV at 20 and 5, and you set a lowest respiratory rate at 8, it will flip between 20 and 5 and try and ventilate them like that. The problem with that is that you're having to deliver inspiratory pressure. Now, CPAP is generally considered better than NIV to overcome the shunt in these patients. The reason being is that what you're trying to avoid is insufflation of gas into the stomach, and therefore increasing the risk of regurgitation during the RSI. And the way to do that is to not have your pressures exceed roughly 20 centimetres of water, because the lower esophageal opening pressure is roughly 20 centimetres of water. So if you can stay below 20 centimetres of water, then you're unlikely to be insufflating the stomach with gas. So if you're using NIV, then you've got this additional inspiratory pressure, which is of no benefit to really overcome the shunt, but might be increasing the risk of regurgitation for your patient. So you're better generally sticking to CPAP. So if you use the ST mode, you have to have a pressure support to ventilate the patient. If you use the NIV without the ST mode, what will happen is that the ventilator, you set up a backup rate, and it will flip into pressure controlled ventilation once the patient becomes apneic after a period of about 10 seconds. And then you can set your backup rate. You can also set up the IE ratio and various other things. So it will actively ventilate your patient during the apneic period. And then you do your intubation down here. And once you've intubated the patient, you just flip the Hamilton into the settings that you want for ventilation. An even easier way to do this is to actually just set the Hamilton up to SIMV. And use SIMV with a bag. The problem is that the Hamilton isn't set up to accommodate for the leak that may happen in that situation, because it's expecting it to be a closed system. Does that make sense? So VAPOX, to my mind, is a really simple but elegant solution to this problem when you want to bag the patient during their apneic period. And it overcomes the human error that might happen where you're going to bag too hard and too fast because you're a bit excited because the patient's hypoxic. So on to another case. So this patient is essentially a generic difficult airway. So we're just going to talk a little bit about difficult airways in the emergency department and how we might manage them. So traditionally, we'd either just crack on and do an RSI on this patient, which has got a high risk of failure. And with this patient with upper airway obstruction, then our plan B and plan C is also likely to fail if the intubation has failed. So we're left with plan D, the surgical airway in these cases. The other option is calling anaesthetics to do an awake fibre optic intubation for these patients. But what happens if we don't have time for anaesthetics to get there, or we can't safely move the patient to theatre? Can we be doing something in ED for these patients? So we can actually consider doing our own awake intubation in the emergency department, and it's nowhere near as hard as the anaesthetists make out. Initially, at least, what we're not doing is an awake fibre optic intubation using an endoscope through the nose. We can actually just have the patient awake. anaesthetize their airway, but intubate them in the standard way with some modifications. The benefit of doing an awake intubation in these patients is twofold. One, you don't burn your bridges, so your only exit is a surgical airway if they're presumed to be difficult. And secondly, the patient continues to breathe because they're awake, and therefore doesn't desaturate, doesn't become hypoxic during the procedure, and it gives you plenty of time to actually do the intubation because the patient's still breathing. And if you're applying nasal oxygen whilst they're breathing and you're intubating them through the mouth, they continue to maintain their oxygen during this. And if it doesn't work, yet you essentially haven't lost anything. You just stop and you come up with another plan, but the patient hasn't been put to sleep, and most importantly, hasn't been paralysed. Now, what awake intubation isn't is a sort of ketamine facilitated intubation, just giving the patient ketamine and then attempting to intubate them without paralysis. That, in the literature, has a pretty high failure rate. And if you're going to do that, the argument may be that you actually just go on to perform the RSI with paralysis because you're likely to be more successful than just doing ketamine facilitated. What you can do, though, is add small doses of ketamine to your topicalisation with lignocaine to try and improve the situation. Now, I'm not going to go further into the process of topicalisation. It's not that complex, but it's going to take a bit of time to go through. The best resource that I've found on it is a group from Canada led by George Kovac called the AIME Airway, so AIME. And there's a whole series of videos that they've posted on YouTube about this, which are really useful to use. But you just need one of these easy spray things that attaches to wall oxygen and atomizes lignocaine into the throat. Then you put a blob of lignocaine on a tongue depressor and let that melt down the back of the tongue. And then you squirt some more lignocaine down onto the cords once you've got a view of the cords or similar, and then you pass the tube. And once the tube's in, you then sedate and paralyse your patient as you would normally. But if you don't get to the stage of being able to intubate the patient, you really haven't lost anything. The only risk with this really is lignocaine toxicity, so being careful about the doses you use.
Really silly question. If you see the cords, you don't need this.
So Hans has just said if you see the cords, you don't need this. Just explain, Hans. I don't see what you mean.
I mean, that you don't have a difficult incubation.
Yeah, but to be able to see the cords, you need to anaesthetise the airway. You can't pass a laryngoscope into somebody's mouth.
Once I get a good view of the cord, rather than squirting stuff down there,
I see what you mean.
Shove the tube down.
So I think what Hans is saying, instead of actually shoving local anaesthetic down into the airway distal to the cords, just shove the tube down. One thing that you can do while the patient's still awake, and what they advocate, is that you use the easy spray and either squirt through the nose as they're inspiring or squirt through the mouth. This has got a directional nozzle that you can point directly downwards. And as they take a breath in, or if they're not compliant, you coordinate it with their in-breath, you squirt, and that goes down the cords anyway. There's a tiny risk of it causing laryngospasm. That would be the drawback of doing this. But the problem is if you shove a tube through unanaesthetised cords, as soon as you hit the cords, they may go into laryngospasm, and you can't then advance the.
But once you've got a view, you sort of establish that you actually don't have the problem that you are anticipating. I mean, I've certainly seen the anaesthetizing below the cords transcutaneous.
Yes.
I mean, that's sort of.
I don't know if you heard that, but Hans said that there's other modes of anaesthesia here, in that you can do a transtracheal lignocaine injection beneath the cords as well, and there are a multitude of options. One of the drawbacks, which I'll come onto in the next slide, is that you get a good view and it looks like you'll be able to intubate easily, but you actually can't intubate the patient, and we'll talk about that in a second.
Just briefly, are you tomahawk in front of the patient, standing up behind them?
I'll come on to that.
Right.
So Marty's just asking about the technicalities. Let's move on and we'll cover hopefully the answers to both of these. So doing it with standard laryngoscopy, you can either use the standard CMAC blade or you can use the D blade. If you're using the D blade, then the view of the cords is only going to be on the monitor. I would advocate that the D blade is a really useful tool, but the problem with the D blade, not just for awake intubations, but for RSIs as well, is that the view is often very good, but the intubation is difficult. So in our easier emergency intubations, why don't we start playing with the D blade so that we get used to intubating easy airways before we're confronted with a difficult airway that we're then going to struggle to intubate. Anyway, here is a video for you to watch of, so this is George Kovac of the AIM Airway. This is off his YouTube site. Hopefully this will work. So this is the lignocaine lollipop stage of the local anesthesia. Now this is what they describe as precision laryngoscopy. The patient is sat up, the intubator is over their left shoulder and stood on a stool, and he's attempting not to touch the tongue at all here. So although the patient's got topicalization, he wants to limit the stimulation. He's using a standard CMAC 4 blade at this stage. So he's doing this direct with direct vision, but we can also see on the camera the view that he's getting. Now this is with the CMAC D blade. Still introduces the device under direct vision because you don't want to be hitting the structures inadvertently. But once you've got round the curve of the tongue, then you move to looking at the screen. This technique of precision laryngoscopy or no-touch laryngoscopy is useful for other things as well. So for example, a neurocritical intubation where you don't want the sympathetic surge that's caused by laryngoscopy. If you can limit stimulation during laryngoscopy, you're going to get less surge. So doing this sort of technique during a neurocritical intubation, let's say a dissection or a subarachnoid hemorrhage, makes sense. So what about the patient with massive hematemesis, or even the patient who's obtunded, who's got a belly full of vomit that may come up and cause problems during the intubation? There's some novel things that we can consider here as well, which I'll go through. So the first is a technique called the salad technique, which is going to be demonstrated in this video, and it stands for suction-assisted laryngoscopy and decontamination, airway decontamination, I think. Now, they use a proprietary sucker that's bigger than the Yanker sucker. This was devised by an anaesthetist in the States called Jim DeCanto. And he's got a sucker that's called a DeCanto sucker that you'll see here. It's a bigger bore than a Yanker, and therefore it can suck up a lot more stuff quickly than the Yanker can. So let's watch the video. So he's using a McGrath blade here, but any video or direct device. The sucker is put in using this sort of alternate grip, and it's just rammed back into the pharynx. And then we use the video to see what we're sucking down into the oropharynx and then into the airway if needs be. And then what he does, it's difficult for you guys to see on the screen, I think, but he rams the sucker down into the top of the esophagus. The problem then is that blocks the view, so he actually just switches the sucker over to the other side, so it's to the left side of his left hand and not in the way of intubation, and then just does a bougie-assisted intubation with the sucker still down in the top of the esophagus. You can't see it, but that's the sucker there. He's just going to show an alternative technique now. What happens if you can't get the bougie into the airway? So he's put the sucker into the airway, takes the suction off, puts the bougie down the sucker, takes off the sucker, and then railroads a tube over the top, which is a really nice, novel little technique if you're faced with a catastrophic airway that's either full of vomit or full of blood. So this is called the salad technique, and there's a bit of stuff on the internet if you search for the salad technique. It doesn't need to use this DeCanto sucker, but it certainly it gives a benefit, and it allows that additional step of being able to pass a bougie through this suction device.
So it's sort of semi-rigid that they can do the device?
It's rigid like a Yanker. It's the right curvature, so it's more curved than a Yanker, and it's a wider bore, so it allows the bougie to go through.
Described a long time ago that you can, I'm not sure how to join it up, but you can attach the suction to your tube.
Okay, I'll show you that in the next slide. Hans is preempting everything that I'm going to talk about here. But so something else that we can do is actually use the ET tube as a suction device, using something that we have in our emergency department easily already. So this is a meconium aspirator on the PEDS trolley, and it allows connection of the suction to the ET tube. Okay, so you can attach the suction to the ET tube, suck through the ET tube as you're looking into the airway and advancing into the airway, and then remove the suction and connect your BVM or similar once you're in the airway. Now, obviously, that's going to lead to a little bit of soiling of the airway because you're using the ET tube as a sucker, but it's going to lead to a lot less soiling of the airway, of having an esophagus and pharynx full of vomit that's otherwise just going to fall into the airway. So it's a nice little trick that we can use. And I'm going to aim to put these into the intubation drawer of our airway trolleys, so that they're there and easily available in those patients that are predicted to be at risk of vomit or have hematemesis or massive hemoptysis or something like that, where your view is going to be obstructed by fluid and other stuff. Just a couple of other things that I wanted to talk about. So this is our current plan for failure, which is on the back side of the checklist, and it has 3 plans. Plan A, intubation. Plan B is sort of twofold, of maintain oxygenation either with a BVM or an LMA, and Plan C is the surgical airway. And that doesn't match up with our trolley either at Sunshine or the trolley that we've got at Footscray currently. Both of those trolleys have a 4-fold failed airway plan. Like so. So plan A is still intubation, plan B is now bag valve mask, plan C is a supraglottic airway, which could either be an iGel or an LMA, and I'll come on to that, and plan D is a surgical airway. So I suggest, if everyone's happy, we move on to instigating this plan, which is more in keeping with the way that the trolleys are set up. And the only other difference is that instead of this now being LMA, it's supraglottic airway with the option of either iGel or LMA. There are other plans in place. So the Vortex is something that's often used, especially in anaesthetics. And it's a really neat little device, I think, for thinking about your backup plans. The drawback from an ED point of view is that it allows you to start from any point in this blue zone, so it's more suited to anaesthesia, where their primary plan might be to bag the patient or to insert an LMA, whereas our primary plan in ED is always to intubate the patient. So we're always going generally in that order of plan A, intubation, plan B, bag valve mask, plan C, LMA, and plan D, surgical airway. The only difference is in that anatomically or pathologically difficult airway, where we actually might just forego plan B and C and go straight to plan D, the surgical airway, when it's inevitable that we're not going to be able to secure the airway from above. So I've mentioned the iGel briefly. Now, currently on the trolleys, we stock 2 different types of supraglottic airway. There's an LMA classic, and there's a fast track or intubating LMA. And every time I come to work, the LMA seems to have changed, the LMA classic, to another device that anaesthesists have purchased, which is cheaper than the last device. And they're significantly different to one another. So currently connection seems to have died. Have you got any questions so far, guys, whilst we're sorting out the technical stuff?
We're going to get iGels?
Well, that's something to discuss today, but I'll talk about the pros and cons now, but to my mind it's a no-brainer that we use iGels instead of LMAs.
The only comment would be, going back a little bit, but the ET tube connected to the suction.
Yeah.
Or suction. You could just stick that down and leave it. You can not shoot out and push that down.
Yeah.
Just like you did in the demonstration with the Soleil technique.
Yeah. The benefit of having the decanto sucker as opposed to the ET is it's rigid.
Yeah.
So that, it's more directional than an ET. You can have the suction with the Y connector, so that you put a stylet through the Y connector, and then still connect the meconium aspirator, and you've got the stylet in place or a bougie in place to make it rigid, but that's slightly more cumbersome.
You got the gear for the awake.
So the gear for the awake in terms of the anaesthetic, what we'd use in theatre and what various other emergency people suggest is 4% lignocaine, as opposed to here we've got 10% lignocaine, which you need to dilute, and it's in a sort of sealed, pressurised jobby. But it's just 4% aqueous xylocaine, it's called, and you put that through the easy spray, and you spray everything inside, and then you try and spray the cords, which we don't have currently, but it's easy to get. They've got it in theatre.
The actual spraying thing?
The nozzles.
It's fine. It's the extension part. If you're doing the magic, because usually the Nico's an atomizer device.
Yeah.
The actual long bit that attaches to the syringe we don't have.
So to go back to your point, Andy, so you can either use a mucosal atomizer device, a MAD, or you can use an easy spray or an easy atomizer, one or the other. Adri, one of the anaesthetists here, has managed to get hold of the easy spray from the States. It's not currently available in Australia, but he can get it for his practice upstairs. I get on with him very well. It would be very easy. He's quite averse to us doing awakes in ED, but I think the reason for that is that their idea of awake is awake fibre optic nasal intubation, which involves a whole different set of skills of actually using the fibre optic scope. So going back to the point, we need 5% aqueous lignocaine to put in the easy spray or the MAD. The easy spray seems to have benefits over the MAD in that it's more directional and it gives better atomization. The MAD is just a syringe attached to a thing which you plunge. Whereas the easy spray, you just press a button and to occlude the lumen, and it sprays as you want it to. And you put a volume of like 10 mils into that. And then you have 5% lignocaine ointment, which again we don't have in ED, but they have in theatre. You put that on a tongue depressor, and you have a mil or two, and you just run it along the back of the tongue very gently and allow it to melt down the back of the tongue to essentially coat the sort of molecular area and the piriform fossa either side of the airway and onto the airway, because that's often the most stimulating part when you're doing laryngoscopy. And even with that precision laryngoscopy, you're still going to need a little bit of lift at that stage when you get the tip of the laryngoscope into the molecular. Are they there?
Yeah.
Yay. Okay. So iGel. So to me, it's a no-brainer that we move over because it means we can use one device instead of the two. And it also means it's always an iGel as opposed to whatever type of classic LMA upstairs has purchased this month and we're forced to use, having no familiarity with it. So as you can see, it doesn't have a cuff. So it's just got a thermoplastic bit at the end, which you don't need to inflate, which makes insertion easier and simpler. You don't have to worry about how much air you put in beforehand, how much air you put in afterwards. That step is removed, and this is thermoplastic. So as it warms up, it molds, and it molds at least as well as a standard LMA to the supraglottic area. It's also got a port that you can see, which is a gastric port, which you can put a small bore nasogastric down to aspirate the esophagus. So that you're reducing the risk of contamination. It's color-coded for sizing, and most importantly, you can intubate down it. So a size 4 iGel, which is the same as a size 4 LMA, will take a size 7 tube, and a size 5 will take a size 8 tube. So you can get a decent sized tube down it. Now, doing a blind intubation down either an LMA or an iGel is generally not recommended, but the one drawback is that the rates of blind intubation success rate is less with this than with a fast track. So success rate with this is about 75% in trained hands, whereas with the fast track it's about 90%. But that's a single study basing that, and generally we shouldn't be doing it blind. We should at that stage have time to regroup, get a scope down from theatre and actually do the intubation using a fibre optic scope and potentially an Aintree catheter, as opposed to just blindly going down, which can cause a lot of problems. So this is the last slide, I think. So moves us on to the checklist, and I just wanted to have a bit of a discussion about the current checklist. So we, as far as I'm aware now, have made decisions both here and at Sunshine that the checklist is going to be mandatory because of near misses regarding the airway recently. And in those cases, as far as I'm aware, the checklist wasn't used for no good reason. There was not necessarily an appropriate backup plan made, and when things didn't go as initially planned, things headed south very quickly. So I think we've got agreement now that the checklist is mandatory, and it's also going to be a challenge response checklist where somebody, I suggest that's the scribe, calls it out, and we respond with the answer, and there's a tick box that you can then tick to say that you've covered each point. And if you haven't covered a point, then there needs to be an explanation why we haven't done something, or probably more importantly, an explanation why we haven't used the checklist for intubation. Mike Stone is just at the back of the room here as well, and he made a good point that maybe we should be introducing Riskman for the non-use of checklist for RSI, because it's such a valuable tool, and we've proved time and time again that our complication rate for RSI is pretty high, and we should be doing things to reduce that. The other thing that I wanted to talk about on the checklist is what we have on there and what we don't have on there. This was discussed at length when it was introduced a few years ago now, and after multiple meetings and discussions, it was decided that this would be the sort of Goldilocks level of not too much and not too little. But if anyone has any thoughts about things to either remove or additional things to add, just let us know at the end. So that's it from me. So just a reminder that intubations in the emergency department are difficult, and the key to mitigating against that is planning. We should aim to modify our technique based on the patient assessment, both their anatomy and their physiology. And everything that we're doing in the planning stage is really there to reduce risk and buy ourselves time to make the procedure more easy. A lot of the time we won't need to use those fallback measures, but they're there when we need to, hence the belt and braces analogy. There's so much to cover, and it's very easy to forget a lot of these things, even if you're doing this regularly. So using a checklist, to my mind, is a complete no-brainer to make sure that we cover everything. Thank you.
Thanks, Stacy. Quick thought on what do you think about doing drills in ED every week on an intubation simulator? Just to do this, the plan, but as you prepped it, so like if you do it every week, you go, I want a size such tube, and I'd like those drugs, and I'm going to intubate like this. This is my plan A, and if plan A is so well drilled that the team knows it, so it just happens. So it's almost, I find that a lot of intubations get complications because the team hasn't been together before. This is a different consultant and a different registrar, and so I'm very conscious that week one, this week, I've just no idea who can intubate apart from me. And
let me stop you so I can tell them the question. So John Loy has just asked a question as to what do I and we think about having practice drills for both the intubation but the use of the checklist and going through the backup plans. And this is done in a ton of other services where, you know, they drill this day in, day out, and it would be something, to my mind, incredibly easy to set up. We could have an airway mannequin left in here or somewhere else, and we could pull staff off the floor for a 15-minute simulation.
I wouldn't even pull stuff off
drill.
the floor, I would do it in recess.
Yeah, or do it in recess. Yeah.
Because it's all about knowing where everything is. So whether we're using, you can have to either pull the airway trolley off the floor, or we actually do it in the environment we're doing it in. So it is actually a proper muscle memory sort of response.
One of these about, it must be 2 years ago, where we had resus, what was in resus 3. And we had it all planned to be done on a certain day, and of course resus was full. But we did it another day.
So Andy's just suggested that instead of doing this in this room or somewhere else, that we actually do it in recess, which I think is a great idea, both using the kit that we should be using day to day, but also using the staff, including the nursing staff that are in there.
If that trolley's there, and you have a airway sim model, so you're doing your laryngoscopy, you've got your tube, and you've got your eye gel or your LMA, whatever choice it is, fast track or eye gel, and you've done your plan A, plan B, plan A, plan B, then the step to D isn't that far, and you might have actually pulled out the kit and looked at it.
Can you hear what John's saying?
4 times rather than never. So it actually moves you down the pathway much quicker.
Yeah. So the only drawback
allocation of roles, and perhaps maybe allocating people to resus, like we don't tend to do so well at the moment, certainly at Sunshine, is actually at the beginning of a shift saying, right, who's consultant resus, who's registrar resus, and that would be an opportunity to introduce and run through a drill and check equipment.
Yeah.
I think that's been suggested before, just from the nursing perspective. I can't remember who suggested it, but if you're allocated to, the doctor allocated to resus goes and introduces themselves to the team that's in there, and whoever's allocated airway go through what your plan would be if intubation was to occur. I think that would be good in conjunction with what you're saying as well.
And as most of you are aware, the discussion at the consultants sort of brainstorming meeting that Ainsley led here not so long ago, one of the things there was introducing standard operating procedures initially for the critical care patients, so an SOP for RSI. And obviously there's lots of discussion as to how specific you want to be in that, in terms of, you know, what kit you should use, and if you're not using it, why not, and also what drugs you should use and roles and that sort of thing. So you can be as specific or non-specific as you want to be within the SOP, but having an SOP so that all staff are more familiar with what should be expected, as opposed to the current situation, whereas you know, an RSI is thrust upon us, and the staff often have absolutely no idea what is expected of them, what's expected to happen, and what's gonna come. Should we stop there so Michael and Marty can speak? Did they have any questions?
No, they're fine.